Hi, so I'm John. I am a third year medical student at the University of Bristol, and here is a first look into my clinical simulator app that I've made. So I've noticed that the university has been looking into simulating patient scenarios through technology recently, and in my opinion, there's yet to be an affordable solution that works in the classroom, at home, and is genuinely considered to be useful by students. So I figured I'd send you my app to get it out there for some potential consideration and feedback. Now, this app isn't publicly available at the moment. In fact, I made it mostly to get a publication on medical education for my portfolio. However, after lots of feedback from my peers on placement, I now genuinely feel that it could deserve a place on the university of curriculum. So far, people have really enjoyed learning on it and have found it to be beneficial with their sort of clinical strategies and also communication with patients. So the app is made for cases that we would expect to present to ED, GP, or a pre-hospital setting. You can see in this one it's ED with the vitals monitor. And it's worth noting that anyone with an admin login can really easily make their own custom cases with personalized learning objectives, deterioration timelines, intervention effects, personalities, etc. through our admin portal. So we did this with the intention of sort of letting the university have a big catalogue of cases like we have, but also letting them make their own ones to say fit CBL or EC or simulations that are coming up, and just allowing them to really customize the platform to them. So the aim with each scenario essentially is to narrow down your differentials until you can come up with a management plan. Now this can be a treatment, it can be a referral. It really depends on what you've set by the admin portal. And then once these endpoints are hit, we go straight to a debrief room where there is sort of all your feedback, everything that happened, and it's all broken down nicely. And we will see this at the end of the demonstration here. So let's hop into this case. So this is what our simulation page looks like. We have a timer here at the top. It usually runs for about an hour, can be extended, can be made shorter. It really depends on what you want. We can press play to start. See here. And the timer will start. Now we can also pause it. This is really good for when you're in a tutorial setting. It means you can pause and have a chat with all of the peers, students, etc., and just really break down what's happening and make a plan together. Now, say if you're a first or second year student, this can be really, really useful as they are likely out of their depth in proper clinical scenarios, and it just allows them to properly bring their thoughts together as a team. Whereas, say if you're with fourth or fifth year students, they may want to do this whilst the timer is running. We can then skip forward here with 1 minute or 5 minutes. This means that say you're waiting on an investigation, there's no more sort of hanging about waiting. We can just skip forward to it if we want to. Now the patient will still deteriorate over this time if that was coded in. However, if they're also getting better, this will also happen over the time. So that's another benefit. And then finally, we can also set the speed to be faster, slower, whatever we may please. Now on the left here, we have patient details. So this is Alex Turner, a 26-year-old male. And then we have blood results here. We can get all of the blood results that you'd expect to get in an ED setting. And when requested from the nurse, they will appear here, as we will show later. And then the same with investigations. This can be ECGs, chest x-rays, etc. And they will all appear here. And then we have applied interventions in the bottom left. This can be referrals or it can be actual interventions. You'll see throughout the scenario that they will stack up here, just to keep track. And then in the middle, we have our OBS monitor. It's been designed to be really, really realistic to an ED one here. We can have simplified versions for GP simulations and pre-hospital settings as well. And then we have nurse and patient chats here. So the nurse chat is to do A to E assessments, it's to get OBS, it's to do interventions, it's to get blood results. Essentially, it's your portal for getting all of your clinical tasks done. And then here we have the patient who we can get a full history from. We can see how they are finding the interventions are affecting them. So say they rate their pain as an 8 out of 10 and we give them some morphine. If you then go back in about 10 or so minutes time, you'll notice that it is decreasing when we ask them. So it's really nice. It's quite realistic in terms of how it impacts the patient as well. Now you can text to talk to them or we can speak. For this demonstration, I'm going to speak because I personally prefer that. Although if you're in a setting where you couldn't type, say, I don't know, a student was using it in the library, they are very welcome to type rather than speak. So let's get started. So there's an ambulance hand over here. This is Mr. Alex Turner, a 26-year-old male who's come into the emergency department 30 minutes ago with sudden onset shortness of breath. The symptoms began while he was playing basketball about an hour ago. Previously well, with no significant medical history, and he has sort of severe shortness of breath, low sats, tachycardic. and now we're here to review him in ED. So if I was here and knew a patient was coming in off an ambulance, I would get the nurse to get obs as soon as they came in. So let's press play and get started. Hi, could you get me all observations, please? So you can see here they're loading. This will take about 30 seconds. It could be instant if you wanted it to be, but we've set it at 30 just for a bit of realism. You shouldn't expect to get obs instantly, of course. So whilst those are coming in, let's talk to the patient. Hello, could I get your name and date of birth, please? So yeah, Alex Turner, 14th of May, 1999. So that is the patient. So Alex, what's brought you in here today? Ooh. Now we can mute that. I'm assuming you can hear the beep through the demo video, and our obs have come in, and our SATs are low and rest rate's high. So let's come back to patient history in a minute. Right now our priority is getting them on some oxygen. Hi, could we get the patient on 15 litre non-rebreathed oxygen, please? Now, something that's really good is the fact that you don't have to ask for, say, 15 litre non-rebreathed mask. You could just ask for oxygen. So if you are a first or second year student, that's ideal. If you're in your later years, then of course you want to be more clinically accurate. And this is broken down in the debrief again, so we can set it to have different objectives for different year groups. So you can see in the bottom left, the intervention has been applied. Now, just for the sake of this demonstration, I'm going to skip 5 minutes ahead and show you how these SATs will increase. So you can see they're going up and up. And we're 10 minutes in, SATs are up to 94. But you can see his blood pressure's dropped. So again, hi, could we please get the patient on some fluids? Right, so the patient is on fluids now. So that's going to help with the blood pressure. And I've just paused it here to have a bit of a clinical think. So, patients come in, shortness of breath, sort of with an instant start, I believe, from the handover, although we will check. Their SATs were really low and they started going quite hypertensive. So this is quite serious. However, we've done well with the nurse so far. We've got a lot of obs and we've put them on some sort of stabilising interventions. So let's continue. So he says, started suddenly when he was playing basketball earlier and it's gotten worse, chest feels tight, can't get enough air. Okay. And Alex, are you in any pain at all? So he's in pain. So there's a sharp pain on his left side, maybe like a 7 or an 8 out of 10. And he says it gets worse when he breathes in. He thinks it could be a blood clot or something in his lungs. Alex, what makes you think it's a blood clot? So his grandma died of a blood clot in her lungs, and this is started so suddenly as well. And he's just, basically he's concerned of a past medical history of a family member. So let's get some blood. So let's get a D dimer and ABG and etc. Hi, could you get me a D dimer, an ECG, and a chest X-ray, please? So these will be requested here, as you can see. And now if we go into blood results, that'll be ready in a minute. Investigations, ECG will be 3 minutes, chest X-ray will be 10. So in this sort of acute setting, what we're looking at is actually an A to E assessment, most likely. So let's get started with that. Is the patient's airway clear? So it's patent and clear, so it's not an airway issue. And what are the patient's breath sounds like? Absent breath sounds left side. Okay. And what is the percussion of the chest like? Hyperresonant on left side. So we're looking at maybe a tension pneumothorax here. So tracheal deviation would be a good thing to check. Hi, can we just check if there's any tracheal deviation, please? Right, trachea is deviated. So what this means is that we basically have a tension pneumothorax based off the clinical picture. Now, as we know, we should be treating off the clinical picture, not, say, X-rays and etc. So we're going to do a needle aspiration, but first I'm going to request a chest X-ray just to show how the system works. Hi, could I get a chest X-ray, please? Right. Chest X-ray. Actually, we ordered one earlier, didn't we? So there's only 1 minute to not 1 minute. We've been 1 minute through, so there's 9 minutes to go. And blood results come in. D-dimer. The D-dimer level is completely normal, so we're not thinking PE. So let's tell the patient this. Yeah, so hi Alex. We did a test for the blood clot and we don't believe it is based off the blood test. However, what we are concerned about is a collapsed lung based on some of the clinical findings. So what we're going to need to do about this is we're going to need to sort of drain some of the area from around your lung and just reduce the pressure a bit, if that is okay. So, okay, yeah, that makes sense. Collapsed lung, serious. And he wants a bit of pain relief as well. Yeah, so we can give you some pain relief on top of that with some morphine. Is that what you would like? Yeah, please. Pain is unbearable. Da, 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 da. Okay. So, hi, can we put the patient on some morphine, please? And could we also get a needle aspiration, please, of the chest? Right, so we've done a needle aspiration, which should stabilise the patient a bit. Now, a definitive treatment here would be a chest drain. However, what I'm going to do is I'm going to skip ahead to A, show the pain relief effects, and B, I'm going to show you the chest x-ray. So, right. ECG. You can look at an ECG. This ECG is completely normal. Obviously, this does help with, if we had sort of cardiac presentations, we could use this. Now, chest x-ray. This is quite a clear pneumothorax. You can see the collapsed lung there. So, yeah. Sorry, our alarms are going. And what else are we going to see? Pain. Yeah, so. Hi, Alex. Is the pain any better? Yeah, bit better now. Morphine's helping. Sorry, I'm feeling kind of fuzzy. Still hard to breathe. Okay, so basically we need to do a chest drain. We know it's pneumothorax, and let's get the treatment finished. Hi, could we get a chest drain on the patient, please? There we go. Simulation complete. So we have hit the endpoint goal, which was to do a chest drain. So let's continue to debrief. So it took us 26 minutes, did 5 interventions, and the scenario was a pneumothorax. We can see exactly when we applied every intervention. We can see exactly which blood tests we ordered. We can see exactly which investigations we ordered. And here we get a full breakdown. Now, one thing I noticed with the, the platforms we've been using for sort of AI communication, the feedback was way too heavy, was the feedback that I got from the other students. So we've gone with simplified, easy strengths and weaknesses. Now, this again can be adapted by the admin. If you'd like more, you can ask for more. If you'd like less, you can ask for less. So you can see here, strength. We systematically gathered vital signs at the start, which is the correct step. Recognized key clinical red flags. As you can see with the absent on left percussion, on absent breath sounds on the left, the hyperresonant percussion and tracheal deviation. However, we ordered a D-dimer at 12 minutes, which wasn't indicated for pneumothorax and consumed time. This is true. Again, this is a clinical diagnosis, so we shouldn't need imaging and etc. But we correctly identified the clinical signs. However, we delayed acting on them by pursuing investigations. This was mentioned in the scenario as it was, as we were going to do it just for demonstration regions. However, it's very good that it's picked this up, as this is a common misconception with tracheal deviations and the underlying pneumothorax. So, and then we have clinical management. So strength, we got high flow oxygen on very quickly with IV access with fluids. And then we did get the definitive management. However, timing was a critical issue here. We spent 12 minutes gathering investigations before taking action on the patient, even though they had tracheal deviation, absent breath sounds, and hypertension implied by the distress. And yeah, we have nice guidelines and advanced ATLS principles stating that needle compression should occur before imaging in a hemodynamically unstable patient with tension pneumothorax. So overall, good systematic assessment skills and recognise a correct diagnosis from clinical examination, but our management was delayed, with the key learning point being that in a patient with clinical signs of tension pneumothorax, act first and image later. This is a treat first diagnosis, and then we can ask more cases, more questions about the cases. So let's just to show off the system. So how does a chest drain work? So it knows all about the simulation so far, so we can get a full breakdown. So we get basic principles, what happens normally, what happens in pneumothorax, how the drain fixes it, and exactly how. And in this case, it talks exactly about it in our specific scenario. So there is an overall sort of run through of our platform. This isn't made to replace simulations. This is made to benefit simulations. It's the idea that a student could practice in CBL. They could do 10, 15, and then when they go into the room, you're getting far more use out of the simulation. I mean, as a second year, I remember going into a simulation and having absolutely no idea what I was doing. And if I'd even just known a little bit from something like this, I would have made far more use of that time. And since, as a third year now, I think I've done 3 total simulations. So this could make a huge difference to my sort of clinical reasoning and what I would actually do in a real life scenario. And again, it also allows the opportunity for things like CBL to be far more enjoyable, I guess. I think that's quite a common thing, is that CBL is very dependent on the staff member as to how good it is and how good they are. However, if you have a really good foundation system like this, you can make it far more interactive, and you could say set students homework to go home and do their own investigations and come back to session 2 of the CBL. And yeah, it just makes it far more interactive, and we can track more of what the students are doing. And yeah, I do really think it has a place in the curriculum, and I'd love to talk more about it. Thank you.